A bit about thyroid physiology in pregnancy. The most important thing about pregnancy is that there are two changes which make pregnancy very important. One is the changes in HCG, and the second changes in estrogen. And we'll just look at what really happens. If you look at HCG, you'll see here that the rise in HCG begins at about conception. It starts going right up there at about week 10, and then generally decreases to a nadir by about 20 weeks and then remains a little low. Paralleling this growth, there is a transient decrease in TSH. As the HCG goes up, you will see that the TSH goes down and it is maximally suppressed at about 10 to 12 weeks of pregnancy, and then the effect of TSH or the effect of HCG on the TSH will slowly go away. Now, why does this happen? The learning point here is that in 20% of normal pregnant women, TSH levels decrease in the first trimester of pregnancy to even less than the lower limits of normal, but this has minimal clinical consequences. The decrease of TSH can be by 0.1 milliunits per ml for every 10,000 increase in HCG. So if you have a vesicular mole, you will have a very large increase in HCG and a very large drop in TSH. If you have twin pregnancies, again, it will be larger than the usual pregnancy. But the point that I'm trying to make is that TSH alone should not be used to diagnose hyperthyroidism for the first time in pregnancy. See, very often you will get a TSH screening only from the gynecologist as a routine screening in pregnancy. And if you find that the TSH is low, that doesn't necessarily mean that this patient is hyperthyroid. So be very careful on this particular point. What about TBG? And we have discussed it, that as estrogen increases throughout pregnancy, TBG keeps on increasing, and therefore the T4 values which are bound to this TBG will keep increasing from about weeks to 6 to 9, and they will peak at about week 18 and remain elevated thereafter. Now, I kept this slide, although this is an old slide, to say that T3, T4 values are therefore not useful in pregnant women. But I myself would not agree with that, because now it has been recognized that FT4 values can change in the second and third trimester. So if you have a T4 which is up to 1.5 times the normal non-pregnant value, you're still dealing with a normal person. So if your normal value is say 12, upper limit of T4 is 12 in the lab, and if your T4 value is now coming up to 18, you're fine. You don't need to do anything about it. If it is crossing 18, you might start wondering whether you're dealing with a high level. But T3, T4 is still important, more so because good T3, T4 assays are more available than good FT3, FT4 assays, particularly in the peripheral places. The same thing here about the FT3, FT4. Okay, so the learning point here, right, is that FT4 values immediately below or in the lower part of normal reference range without increase in TSH is a normal finding in pregnancy and does not indicate a disease. It does not require thyroxine replacement. And this just summarizes the whole thing, that the TBG goes up. This is the FT4, which, as I said, goes down in the second trimester. This is HCG. As the HCG goes up, the TSH goes down. And these are summarizing the whole points that are seen in pregnancy. This is something, the last 4 or 5 slides maybe, and this is something which is very interesting, and that is the immune system in pregnancy. Now, you know that normally speaking, in pregnancy, there is a quiescence of the entire autoimmune process, and therefore all autoimmune disorders actually tend to go down in pregnancy. And that is a protective mechanism of the body. But what therefore happens is some fetal cells will escape and go back into the maternal circulation, and what is called microchimerization. And therefore, when the pregnancy is over, they will actually produce something like a graft versus host disease, and therefore a flare-up in the autoimmunity of the mother after the delivery. And that is typically postpartum thyroiditis. So throughout pregnancy, nothing happens, and suddenly postpartum, the whole thing flares up. So basically, concluding that was that understanding thyroid physiology is extremely crucial in interpreting thyroid function tests and proper diagnosis and management of thyroid disease. Abnormal thyroid functions do not necessarily indicate thyroid function abnormalities. Pregnancy is a stress test for the thyroid. Now, just a few things about screening in pregnancy. Now, we are screening that more and more commonly, and therefore we are getting more and more problems. Now, typically, to summarize the whole thing, I'm just going to give you, I'm not going to run through all this at all, but by and large, in India, thyroid diseases in pregnancy are actually becoming common, and they are much more than the West, what is reported in the West. We are not going to go into that really, but it is definitely very common. So what should we be doing? I think the first thing that we should be doing is to check a good TSH level. Now, to diagnose hypothyroidism in pregnancy, we normally say that the TSH should be more than 10 in non-pregnant states. But in pregnancy, even borderline TSH, there is a lot of data to say that treating borderline TSH is actually beneficial for the fetus and the mother. But what is more important is that there are trimester-specific targets for TSH control, 2.5 and below in the first trimester, and 3 and below in the second and third trimester. As far as hyperthyroidism in pregnancy is concerned, the so-called subclinical hyperthyroidism, or what I called as early hyperthyroidism, where your FT3, FT4 are normal and TSH is slightly low, even apart from the HCG mediated effect we saw, that means after week 12, 14, need not be treated, and it is not actually associated with an adverse outcome. So there is a clear difference between testing for hypothyroidism versus testing for hyperthyroidism. Can I have 1 minute more to go on? Yeah, I'm just finishing. So basically the difference is a little there. Now, hyperemesis I have already spoken about. What I just want you to bring to the last slide, and that is the diagnostic algorithm for testing of congenital hypothyroidism. Now, it's a separate topic. I'm not going to go into too much into details. There are different methods of screening. You could do it on the cord blood, you can do it on day 5, you can do it on a filter paper, you can do it on a venous plasma, etc. The point is, do something. Do it whenever, but do a TSH, at least in the patients that you know. Ask them if their babies have been tested for thyroid. The only important thing is, do not test TSH within the first 72 hours after birth, because there is a physiological surge in TSH because of exposure to the colder air as compared to the womb. Therefore, there is brown fat thermogenesis and TSH goes up markedly. So you cannot really interpret it. You can do a cord blood, but cord blood levels are very variable, and there are reports saying that up to 100 TSH can be considered normal in cord blood, and I would be really scared to tell a mother that a TSH of 95 in the child is normal. It's very difficult to do that, and we don't really get them tested again and again. So rather than the cord blood, a day 3 onward TSH is very important, and particularly a simple thing to remember, I don't think you can see all this, is the T4 is less than 9 and the TSH is more than 9 after day 15, you almost always means that the child has some form of thyroid disease and should be evaluated further. So just remember this value of less than 9 T4 and more than 9 T4, more than 9 TSH at 15 days of, after 15 days of birth. So that was about non-pregnant and pregnant physiology. I tried to cram a lot of things because I just wanted to start the thing going. We can discuss these things separately whenever we find time. And thank you once again for your invitation. I hope we have a great 2 days discussion. Thank you so much.